Good morning, and thank you very much for the warm welcome that we had here and the hospitality that we experience now for the second time here is always overwhelming. I was asked to kind of set the scene here a little bit this morning by answering the question, who can become a laparoscopic surgeon? Now, I know that many of you already are laparoscopic surgeons and already very experienced, so maybe this is aiming more at the ones of you who are thinking of becoming laparoscopic surgeons or who are at the very beginning of the learning curve. When I was thinking about the question at first, the answer I think was very clear. Everybody can be a laparoscopic surgeon because you don't really need much if you think about it. The only things that you really need is a brain. You need at least one eye. Ideally you have two. You need a couple of hands. And you need some equipment. And if you put it all together, then you are a laparoscopic surgeon. So yes, it's not really a problem. I think everybody can be a laparoscopic surgeon. But when you start thinking a bit more, then I heard about all these things, that we keep hearing, that laparoscopic surgeons are somehow special people. So can really anybody be a laparoscopic surgeon? So I think at first I want to clarify some things that go around in the scene and people believe. And I think these are beliefs only, and these are only myths. And we should try not to believe too many things that we hear. One of the things that we hear all the time is that before you become a laparoscopic surgeon, you have to be an expert in open surgery. So basically, the argument is that you need to know your anatomy, you need to know everything before you go in with a small camera and you look at small spaces. But if you really believe that, then I have to ask you, how many of you who have learned laparoscopic cholecystectomies have done open cholecystectomies before? Or when you teach your juniors, do you teach them open cholecystectomies so they get the anatomy and then you transfer them, or you then convert to laparoscopic surgery? I don't think so, because it's not necessary. I think you can learn it exactly the same way, or maybe even better sometimes, to understand the spaces and the anatomy by doing it laparoscopically. We were trying a few years ago to analyze this in a more kind of experimental way, and we did an experiment where we are looking at two groups of people. One group were surgeons who had open experience but no laparoscopic experience, and the other group were just surgically naive people who didn't do any open or any laparoscopic surgery. And we put them through an experiment of learning laparoscopic skills. And you can see that they developed exactly the same way. So it didn't really help them to have open skills to become laparoscopic surgeons. So I think this is all dogma, and we should not believe in this, really. Another thing that you often hear is that only people with certain personality traits can become laparoscopic surgeons. And when you look at these personality traits, people say that you need to be particularly patient, you need to pay a lot of attention to detail, you need to have some sort of visual intelligence, you need to be very decisive, and you need to be on a high level of situational awareness. But if these are the personality traits that are required to become a laparoscopic surgeon, I would say these are actually personality traits of any good surgeon. So we all have these personality traits, otherwise we wouldn't be surgeons. So again, I think it's dogma and it's a myth. Another one of those is that you need to be particularly skilled, that you need to have genuine fine motor skills, and you have to have very good hands to do laparoscopic surgery. A little bit like this watchmaker who is dealing with very small parts and he has to be very precise. Again, I think it's not really true. What we are doing with our hands is not very difficult, really. We are just steering around some instruments. And yes, there are the things that you have to translate your skills from a 3D environment onto a 2D screen and all these things that you hear all the time. But it's not that difficult. Anybody can learn it. The real difficulty is how to deal with situations. And someone once put it in the words that laparoscopic surgery is the art of the eye and not the art of the hands. And I think that's very true. So, if these are all just myths, then we should be able to train anybody. We can train a monkey to become a laparoscopic surgeon. I'm not so sure about the monkey, but I'm pretty sure that any good surgeon can become a laparoscopic surgeon. But maybe you need to be prepared. And that's what I want to talk about in the next 10 minutes or so. What are the kind of preparations that you need to take before you start, or before you start thinking, especially for laparoscopic colorectal surgery? I think what you really need are a set of hardware and software. And I would like to start with some of the hardware that you need. One of the things that you can sort out before you start is your environment. I don't think that you all need a fantastic postmodern laparoscopic theatre. Where I work, we don't have that, because we are very poor. Where Amjad works, they have 2 of them, because they're very rich. But I don't think you need that really. But what you need are a few minimum requirements. And I think nowadays, when you do colorectal surgery especially, you should have a good laparoscopic stack with a high definition screen. It just makes things much easier. I think it's very useful to have 2 screens rather than just 1, 2 monitors. And of course you need some sort of energy dissection device and an operating table which you can move in all kinds of directions. So I think these are just a few minimum things that you particularly need for colorectal surgery. And you need to sort out your team, or you need to build a team. And I think there are a few things which are important. I mean, everybody is talking all the time about, the team is very important. This is like a team sport. It's not just a one-man game. And I think it is true, especially when you start. I think when you reach a certain level, or when you're a proper expert, and I wouldn't count myself into this group, but if you are at that level, then you may not need a team. You can go anywhere and you can just operate, and you're in control of everything. But when you start, you're so focused on the things that you're doing that you can't control for everything around you. So the team is actually really important. And I think what has been said before already is that it's important to have a consistent team, that you have the same people who are coming with you all the time, in terms of nurses, in terms of anaesthetists, but also assistants, so that they know what you are doing and you know what they are doing. And I think it is helpful to have 2 assistants. I always try to have 2 assistants, at least for left-sided resections, because again, it just takes some hassle away from you. And you can do something about your environment in terms of having it calm and quiet. From what I have seen so far in Russia, I don't think this is a problem, because your operating theatres are very well organized and you have very good scrub nurses who keep control of things. But in England, you can see often that there is loud music, people are chatting, a lot of people coming in and out, and it's very, very distracting. So try to keep that noise and distraction down as much as you can. And finally, I think you have to set up certain perioperative standards. So not how you do the operation, but how you prepare things. So the way you position the patient, the way your anaesthetist is performing the anesthetic. I'm not going into details here, because I know that tomorrow there's a whole session about this. And how you care for the patient post-operatively. So this is the hardware. But maybe more important is the software. And one of the things is, of course, training. Again, I will not go into details of training, because there will be a special lecture about this, but a few things I would like to mention. We heard before about this learning curve, and just to clarify, this is the same study where we were looking at the learning curve in colorectal surgery, and you can see this long learning curve of having up to 150 procedures. This is not really good, because it means that the measures for this learning curve are things like complication, things like blood loss, etc. So these are negative outcomes. So it means that 100 to 150 patients per surgeon have suffered unnecessary negative outcomes. And what I want to clarify is these surgeons, they were all self-taught. So they had no training, no particular training for colorectal surgery. They were just doing it and trying it and getting there slowly. And what we could show in due course is that if you have a structured training program in place, you can reduce this learning curve from 150 to probably about 30 to 50 cases. It doesn't mean that you come out as a super expert at the end of this, but you are safe, and your outcomes should be consistent and stable. So you need to get trained. There are many ways of getting trained, and ideally you would have something like a fellowship where you stay for 2 or 3 years and you have supervision all the time and you have a good teacher and all this, but you're not always having this. And that's why I'm showing this picture. This picture was sent to me by Alexei a couple of months ago, and you can see this is his team. And what they're doing is they're watching a video of an operation that they did previously. And Alexei was sending me these videos and asking me to write comments. So I watched the videos and I just wrote what I saw and what I thought is useful for him to know. And then he reviewed it with these comments. But what I find particularly interesting is actually reviewed it with his whole team. They were all trying to learn from this somehow. And that was his way or his approach of training within the possibilities that he has. And I think that's the most important thing, that you kind of critically review and critically analyze what you're doing and get some feedback from somewhere. And again, this is from a more experimental study that we did, where we were looking at the effectiveness of training. And the interesting thing was to see, this was one group of surgeons who had no training. They were just training themselves, basically, watching videos and then training themselves. Whereas the other group, they had active training. And they both developed very similarly in terms of their laparoscopic skills. So the way they used the instruments, the way their movements were very similar. But when you looked at the quality of their operations, and this is what these curves represent, there was a significant difference that the ones with training developed a high quality operation much quicker than the others. And that's because they had the input and the feedback from a trainer. And on a higher level, this is important, because in the end, what you do is what you get. So when we look at the results from the training program in England, we can see that what they achieved during that training, so while they were supervised by someone, they achieved certain results. They could actually maintain these results afterwards when they were on their own after the training. So they could retain their skills in such a way that patients did not suffer of unnecessary complications. The second thing is choose your patients wisely when you start. And as you probably all can guess, this patient here is not the ideal candidate for your first laparoscopic colectomy. Again, I don't want to take away the contents of the following talk, but just a quick idea of how you could arrange it for yourself. You can kind of come up with a system for yourself, how you want to choose your patients when you start. We were trying to look at it from a scientific point of view. I don't know whether this is a good selection criteria scheme or not, but there were basically 3 major factors that contribute to the complexity of a case. One is the BMI of the patient, one is the type of resection you're doing, and one is the pathology. So obviously thin patients, colonic procedures rather than pelvic procedures or rectal procedures, female rather than male patients for the pelvis, and small tumors rather than big tumors are probably the right choice at the beginning to keep you safe. And then you can gradually build up on that, because you start with good outcomes, you start with confidence, and then with that you can build up. If you start with something that goes wrong at the beginning, you're more likely to abandon it very quickly. And the other thing that you need to think about is how to standardize your procedures. You have to think a bit like these two guys here in a cockpit of a plane. Imagine if they would take a different approach every time they take off. If they would do a different procedures every time they fly, it probably wouldn't be very good for them. So they have a very standardized way of how they do things. And I think this is something you can do as well. And that's something that certainly I learned during my time as a trainee, to come up with something that is good for you and that is always the same. So it's very familiar from the beginning when you start the procedure. For me, it even starts before I start the procedure itself. It's everything from the way you put on the drapes on the patient, the way you put your wiring on the patient, the way you gain access to the abdomen. Everything is always in the same sequence. And that helps you to put your mind, or to set up your mind in a way that you don't forget things, that you always do the same things. And then finally, and maybe most importantly, you have to learn to slow down. We're usually very impatient. We want to push for things. We have a lot of pressures around us. And the problem in laparoscopic surgery is the more you hurry, the slower you get. So don't try to take any shortcuts. Just do things slowly and calmly, and try to do them once rather than several times. And you will actually arrive much quicker at the end of it. So yes, I think everybody can be a laparoscopic surgeon, but there are some things that you need. And it's not just the brain, the hands, and the equipment, and the eyes, but it's also all the other things I've been talking about. So it's a bit like this. You know, if you take the plane on the left side, you will probably fly, but maybe not very long. So we probably all agree that we would like to take the plane on the right side, because it makes you a bit safer and will make you fly longer. Thank you very much.